Welcome to our comprehensive guide on the management of proximal biceps tendon pathology. The long head of the biceps tendon, or LHBT, is a well-known source of interior shoulder pain, especially in athletes and working individuals. In this video, we'll explore the anatomy, function, evaluation, and treatment options for LHBT disorders, aiming to provide a clear understanding for both clinicians and patients. By the end, you'll have a solid grasp of the latest approaches to managing this common yet complex shoulder issue. Let's begin by understanding why the LHBT is such a significant pain generator and how its pathology impacts daily life. Appreciate the management of biceps tendon pathology. It's essential to understand the anatomy. The LHBT originates from the supraglenoid tubercle and the superior glenoid labrum, exiting the shoulder joint through the bicipital groove. Its attachment varies among individuals, which can influence both function and susceptibility to injury. The tendon is stabilized by a complex pulley system involving several ligaments and tendons, ensuring smooth movement and stability. This intricate anatomy is the foundation for understanding both normal shoulder function and the development of pathologic conditions. Long head of the biceps and the glenoid labrum together form what's known as the biceps labral complex, or BLC. This complex can be divided into three main regions: the inside, which includes the superior labrum and LHBT anchor, the junction where the intraarticular LHBT and its pulley system reside, and the bicipital tunnel, which houses the extraarticular biceps. Each region is associated with specific injuries and clinical presentations, making this classification crucial for diagnosis and treatment planning. Function of the long head of the biceps tendon is still debated among experts. Some studies suggest it acts as a stabilizer for the humeral head, especially during shoulder abduction, while others see it as a vestigial structure with a role in proprioception rather than active movement. What's clear, however, is that the LHBT primarily serves as a forearm supinator, while the short head is more involved in elbow flexion. Understanding these roles helps clinicians tailor treatment to preserve or restore function. Proximal biceps tendon pathology can be classified into three main categories: inflammatory, instability, and traumatic. Inflammatory conditions often result from overuse or degenerative changes, while instability may cause mechanical symptoms like popping or clicking. Traumatic injuries, such as complete ruptures, can lead to sudden pain and visible deformity. Each category is linked to specific shoulder conditions, including rotator cuff tears and labral lesions, which often coexist and complicate diagnosis. Each part of the biceps labral complex is prone to distinct pathologies. The inside region is commonly affected by SLAP lesions, often due to superior migration of the humeral head or internal impingement. The junction is susceptible to LHBT tears, incarceration, and pulley lesions, while the bicipital tunnel can develop tenosynovitis or house loose bodies. Recognizing these associations is key for targeted evaluation and management. Thorough clinical evaluation starts with a detailed patient history and physical examination. Since biceps tendon pain can mimic or coexist with other shoulder disorders, it's important to ask about injury mechanisms, hand dominance, occupational demands, and previous surgeries. Physical examination should assess range of motion, strength, and specific tests to differentiate between inflammatory, instability, and rupture condition. This comprehensive approach helps narrow down the diagnosis and guides further testing. Physical examination for LHBT pathology includes several maneuvers. Inflammatory changes often present as interior shoulder pain radiating to the biceps, worsened by overhead activity. Instability may be detected by reproducible clicking or subluxation, often linked to subscapularis tears. Ruptures typically present with a tearing sensation, swelling, and the classic Popeye deformity. Special tests like the liftoff, belly press, and bear hug help assess subscapularis involvement, while direct palpation of the bicipital groove can localize pain. Several physical examination maneuvers are used to diagnose biceps and SLAP lesions, though many lack specificity. The speed test, which involves resisted elbow flexion, and the Jurgensen test, which uses resisted forearm supination, are commonly performed but have moderate sensitivity and specificity. Tests specific for SLAP pathology like the O'Brien active compression and O'Driscoll dynamic labral shear offer additional clues but are not definitive. These limitations highlight the need for a multimodal diagnostic approach. Physical exams are inconclusive, imaging studies become essential. Standard radiographs help rule out bony abnormalities but are often normal in biceps pathology. MRI offers reasonable sensitivity for SLAP tears and LHBT ruptures but may miss junctional or bicipital tunnel lesions. Ultrasound is a fast, cost-effective option for detecting instability and dynamic changes, though it's less reliable for partial tears. Combining imaging modalities improves diagnostic accuracy and guides treatment decisions. Diagnostic injections can help confirm biceps tendon involvement in shoulder pain. Ultrasound-guided injections into the tendon sheath are both diagnostic and therapeutic, providing pain relief and information about the underlying pathology. It's crucial to avoid injecting directly into the tendon to prevent rupture. Studies show that ultrasound guidance significantly improves injection accuracy compared to blind techniques, making it the preferred approach in clinical practice. Initial treatment for LHBT pathology is typically conservative. This includes non-steroidal anti-inflammatory drugs, physical therapy, activity modification, and ultrasound-guided corticosteroid injections. Physical therapy aims to improve shoulder strength and function, while injections provide short-term pain relief. Other modalities like onaphoresis, shockwave therapy, and regenerative injections are sometimes used, though evidence for their effectiveness is mixed. Most patients respond well to these measures, delaying or avoiding surgery. Physical therapy is a cornerstone of non-surgical management for biceps tendon disorders. It focuses on restoring range of motion, strengthening the rotator cuff and parascapular muscles, and correcting movement patterns that contribute to pain. While research on its effectiveness for LHBT-specific pathology is limited, many patients experience significant improvement in pain and function. Therapy is often combined with other conservative treatments for optimal results. Corticosteroid injections, when placed accurately into the biceps sheath, can provide short-term pain relief for LHBT disorders. Ultrasound guidance is recommended to ensure proper placement and minimize the risk of tendon rupture. While these injections are effective in the short term, their benefits may diminish over time, and repeated use is not always advisable. The decision to use corticosteroids should be individualized based on patient needs and response to other treatment. Beyond physical therapy and corticosteroid injections, other non-surgical treatments include ontophoresis, phonophoresis, shockwave therapy, and regenerative injections like platelet-rich plasma. The evidence supporting these modalities is mixed, with some studies showing benefit and others finding little effect. As research evolves, these options may become more refined, but for now they are considered adjuncts rather than primary treatment. Surgical intervention is reserved for patients who fail to improve with conservative management or those with acute, severe injuries. The main surgical options are biceps tenotomy, biceps tenodesis, and slap repair. The choice of procedure depends on patient age, activity level, cosmetic concerns, and surgeon preference. Each technique has its own indications, benefits, and potential complications, which we'll explore in the following scene. Biceps tenotomy involves cutting the LHBT at its origin while preserving the labrum. It's a quicker, less expensive procedure, often chosen for older patients or those with lower physical demands. While it provides excellent pain relief and functional improvement, complications can include the Popeye deformity, cramping, and fatigue. Recent advances in arthroscopic techniques aim to minimize these issues and improve patient satisfaction. Biceps tenodesis is increasingly popular, especially for younger or more active patients. The procedure involves detaching the LHBT from its origin and reattaching it to the humerus at various locations. This approach preserves muscle contour and strength, making it ideal for those concerned about cosmesis or high physical demands. However, it's technically more challenging and involves a longer recovery compared to tenotomy. Flap repair is a surgical technique used to address superior labrum anterior to posterior lesions. It involves reattaching the torn labrum to the glenet using suture anchors. While this procedure can restore stability and function, especially in younger patients, recent trends show a shift toward biceps tenodesis due to higher rates of revision surgery and variable outcomes, particularly in older or overhead athletes. Biceps tenodesis can be performed using open or arthroscopic techniques. Both methods yield excellent clinical outcomes, with no significant differences in function or complication rates. The choice often depends on surgeon experience and patient-specific factors. Open tenodesis may have a slightly higher risk of wound complications, while arthroscopic approaches can lead to early postoperative stiffness. Ultimately, both are effective when performed correctly. Location of biceps tenodesis can vary: intra-articular, suprapectoral, or subpectoral, with additional options like extra-articular placements. Each site has unique advantages and drawbacks. Intra-articular placement is technically straightforward but may leave residual pain. Suprapectoral and subpectoral placements avoid this but differ in recovery time, bone quality for fixation, and risk of complication. The choice should be individualized based on patient anatomy and pathology. Subpectoral tenodesis is often preferred for patients with significant bicipital groove inflammation or poor tendon quality. This approach eliminates pain from the groove, offers stronger bone for fixation, and may speed up recovery. However, it carries risks like scar formation, muscle asymmetry, and potential nerve injury. Surgeons must weigh these factors when recommending subpectoral tenodesis. Studies comparing intra-articular, suprapectoral, and subpectoral tenodesis show that all three approaches yield excellent clinical outcomes. There are no significant differences in functional scores, range of motion, or strength deficits. This suggests that the choice of tenodesis site can be tailored to individual patient needs and surgeon expertise without compromising overall results. Fixation of the biceps tendon during tenodesis can be achieved using inlay or onlay techniques, with devices like interference screws, suture anchors, or cortical buttons. Inlay fixation is less technically demanding but may fail in poor quality tendon or bone. Onlay fixation, while more complex, may offer superior outcomes. The choice of fixation device and technique depends on patient factors and surgeon preference. Interference screws and suture anchors are the most common fixation devices for tenodesis. Titanium, PEEK, and bioresorbable screws each have unique properties. While some studies suggest interference screws provide stronger fixation, others find no significant difference compared to suture anchors. The decision often comes down to bone quality, tendon health, and the surgeon's familiarity with the device. Biomechanical studies comparing fixation strategies show mixed results. Some report higher failure loads with interference screws, while others find similar outcomes with all suture anchors. Importantly, clinical outcomes do not differ significantly between techniques, suggesting that both are viable options when used appropriately. Surgeons should consider patient-specific factors and potential risks, such as fracture or implant failure, when choosing a fixation method. Pairing biceps tenotomy and tenodesis, studies show both procedures provide excellent pain relief and functional improvement. Tenodesis is favored for younger, active patients or those concerned about appearance, as it preserves muscle contour and reduces the risk of Popeye deformity. Tenotomy is quicker and less expensive, making it suitable for older or less active individuals. Ultimately, the choice depends on patient goals and expectation. Postoperative rehabilitation is crucial for optimal recovery after biceps surgery. Recent research suggests that tenotomy patients may benefit from a short, personalized rehab protocol, leading to faster return to activity. Tenodesis patients typically require a longer, more structured rehabilitation to protect the repair and restore strength. Close collaboration between surgeons, therapists, and patients ensures the best possible outcome. Lap lesions are categorized by type and managed based on patient age and activity level. While non-surgical management and arthroscopic repair were once standard, there's a growing trend toward biceps tendinoses, especially in patients over 40 or athletes. Tendinoses offers higher satisfaction, quicker recovery, and better return to activity rates compared to slap repair, making it the preferred option in many cases. Outcomes after slap repair vary widely, particularly in overhead athletes and older patients. While many experience good satisfaction and return to play, others require revision surgery or have persistent symptoms. This variability has led to increased use of biceps tendinoses, which consistently provides better functional scores and satisfaction, especially in challenging patient populations. Recent data show a significant shift in the management of slap lesions. The proportion of slap repairs has decreased, while biceps tendinoses procedures have risen dramatically. This reflects growing evidence supporting tendinoses as a reliable, effective treatment with fewer complications and better patient-reported outcomes. Surgeons now tailor their approach based on patient characteristics and the latest research. In some cases, surgeons may perform both slap repair and biceps tendinoses, especially in complex or revision cases. However, studies show that combining these procedures may lead to worse outcomes compared to either technique alone. Careful patient selection and individualized treatment planning are essential to avoid unnecessary interventions and optimize recovery. Every surgical procedure carries risks. For tenotomy, complications include Popeye deformity, cramping, and muscle fatigue. Tendinoses may result in infection, fixation failure, nerve injury, or persistent pain. The choice of technique and fixation device can influence the risk profile. Surgeons must discuss these possibilities with patients and monitor closely during recovery. Effective patient counseling is a cornerstone of successful management. Surgeons should explain the pros and cons of each treatment option, set realistic expectations, and involve patients in decision-making. Factors like age, activity level, cosmetic concerns, and personal goals should guide the choice of procedure. Open communication ensures patients are prepared for recovery and satisfied with their outcomes. Summary: proximal biceps tendon pathology is a common cause of shoulder pain, with multiple treatment options available. Non-surgical management remains the first line, but surgical techniques like tenotomy, tendinoses, and slap repair are effective when needed. Recent trends favor biceps tendinoses for many patients, given its excellent outcomes and low complication rates. The decision should always be individualized, balancing evidence with patient preferences. Ongoing research continues to refine our understanding of biceps tendon pathology and its management. Advances in imaging, surgical techniques, and rehabilitation protocols promise even better outcomes in the future. As evidence evolves, clinicians must stay informed and adapt their practice to provide the highest standard of care. Any patients treated for proximal biceps tendon pathology experience significant improvements in pain, function, and quality of life. Whether managed conservatively or surgically, most return to their desired activities with minimal complications. These success stories highlight the effectiveness of modern management strategies and the importance of individualized care. Optimal management of biceps tendon pathology often involves a multidisciplinary team, including orthopedic surgeons, physical therapists, radiologists, and primary care providers. Collaboration ensures comprehensive evaluation, accurate diagnosis, and coordinated care throughout the treatment journey. This team approach maximizes patient outcomes and satisfaction. Educating patients about their condition, treatment options, and expected outcomes is vital. Providing clear, accessible resources empowers patients to participate actively in their care. Visual aids, handouts, and reputable online materials can enhance understanding and support informed decision-making. Successful rehabilitation after biceps surgery requires patience, consistency, and guidance from experienced therapists. Key tips include following prescribed exercises, avoiding premature heavy lifting, and communicating any concerns to the care team. Gradual progression and adherence to the rehab plan are essential for optimal recovery. Most patients can expect to return to their usual activities after appropriate treatment for biceps tendon pathology. The timeline varies depending on the procedure and individual factors, but with proper rehabilitation, outcomes are generally excellent. Athletes and active individuals often regain full function and performance. After treatment, ongoing monitoring is important to detect any recurrence of symptoms or complications. Regular follow-up visits, self-assessment, and prompt reporting of new issues help ensure long-term success. Most recurrences can be managed effectively with timely intervention. The field of orthopedic surgery is constantly evolving, with new research driving innovation in diagnosis and treatment. Ongoing studies aim to improve surgical techniques, develop better fixation devices, and refine rehabilitation protocols. Staying updated with the latest evidence ensures the best care for patients. Recap: proximal biceps tendon pathology is a multifaceted condition requiring a nuanced approach. Conservative management is effective for many, while surgical options like tenotomy and tendinoses offer excellent outcomes when needed. The choice of procedure should be tailored to each patient, considering their unique needs and preferences. Collaboration, education, and evidence-based practice are the pillars of successful management. Thank you for joining us on this journey through the management of proximal biceps tendon pathology. As research advances and techniques evolve, outcomes for patients continue to improve. By staying informed and working together, clinicians and patients can achieve the best possible results. We hope this guide has provided valuable insights and practical knowledge for navigating this important aspect of shoulder health.